Dear colleagues from Albania, I'm honored to have the opportunity to present at your conference one of the most historic and unique at the same time, yet time-tested physical therapy concept that has nurtured generations of physical therapists around the world. The PNF concept. This two-part lecture will present the scientific evidence supporting the concept, but will briefly describe its clinical applications. My name is Adamidis Sakis, and I come from Greece. I'm 30 years physiotherapist and an instructor of the concept for the last 16 years. My clinical interest is focused on both musculoskeletal and neurological rehabilitation, with a particular interest on the spinal disorders and stroke, respectively. The definition of PNF, patient need fun. That actually describes the way you treat the patient in this concept. More officially, proprioceptive neuromuscular facilitation involves the term facilitation, which means make it easy, just make it possible, doable. It involves the neuromuscular system, specifically the brain, which gathers and manages all stimuli, directed to it by the stimulation of the extra and the proprioceptive receptors. This process is directed by the therapist to coordinate the actions of the neuromuscular system in order to guide the reactions of the central nervous system to achieve functional goals of importance to the patient. PNF as an idea has been recently seen as a problem-solving process, with assessment and treatment working hand in hand throughout the process of achieving goals such as improving body functions, activities, but in the end of the day, improving the quality of the lives of the patients. Since the conception of this idea in the middle of the last century, Dr. Cabot and physiotherapist Maginot, which considered the pioneers, integrated many of the concepts of the contemporary neurorehabilitation interventions. The philosophy, the basic principles, and the techniques were the cornerstone of its development. The principles of motor learning were encapsulated very early on by another great lady, Dorothy Voss, who spoke many years ago about the need for the treatment of patients to be related to their real needs and offered in their familiar spaces. Let's look now at the first part of this lecture to see what scientific proof involves. But what might be the minimum proof of the concept to be considered scientifically acceptable has not been determined. However, two things are essential in this process. Biological plausibility. It has to make sense. If the idea is daft, if it's at odds with any well-established biology, chemistry, physics, that's a deal breaker. There cannot be evidence of absence. If there is persuasive trial evidence that shows no benefit or damns a technique with very faint praise, which is extremely common, that's another deal breaker. Although it was difficult to draw definite conclusions due to the lack of cognate and varying methodological quality of papers, a number of studies did demonstrate encouraging results use of PNF, particularly with regard to increasing range of motion. The literature describes that the PNF concept is applied in clinical practice in a variety of populations and indications, such as orthopedic, neurologic, traumatologic, and also in pediatrics, gynecology, internal medicine, and many others. However, efficacy for specific indications and populations requires further investigation. We have plenty of information from literature supporting all parts of PNF-based theory, philosophy basic principles, but also for important functions and activity like gait, ADLs, and vital functions. Indicatively, regarding PNF effectiveness to shoulder girdle dysfunction, the contact and hold relax techniques of PNF applied in upper limb patterns were shown to be effective in decreasing pain and increasing range of motion and function in subjects with a shoulder girdle dysfunction. This review indicates that PNF is a potential treatment strategy in chronic stroke rehabilitation on balance and gait speed. Further, high-quality research is required for including a consensus of intervention and research of PNF. Clinical reasoning is a dominant element in decision-making in PNF intervention. That includes taking a thorough history in which particular attention is paid to the patient's expectations and avoiding contraindications. The external evidence and experience of the therapist are important to select appropriate clinical decision in managing the patient's needs and expectations. In the second part of this lecture, we see the clinical applications which are beautifully described in the book by Adler, Beckers, and Book that I had the honor of being their student. The assessment and treatment and all indications follow the ISEF model, which places particular emphasis on the environment and the specific characteristics of the patient, which together with their capabilities, body functions, activities, and social benefits or limitations, determine the framework of this innovation. Philosophy, basic principles, and techniques are really altogether consist the heart theory, the heart base of the theory of the PNF concept. If we see the philosophy, there are about 5 important elements, topics, which are really characterize the principles within the philosophy of PNF. The first is the integrated approach. In other words, that means that within the PNF concept, we see the whole perspectives of the person, not just only the sensory motoric aspects, but also the cognition and the emotion. We also are interested on the environment that this patient acts and the type of the activity, the task which is the person is taking, bringing him into action. Positive approach is something unique, I would say, in rehabilitation, as from the assessment, we are strongly interested about the possible activities. We look for the strong body parts. We use these strong body parts to affect the weaker parts. We start with easy activities and we try to avoid pain. Mobilizing reserves means that every patient has a potential to develop through the activities, which means that we use the principles of irradiation, which connects the strong parts of the body with the weaker parts of the body, and also with an interesting indirect approach. When we treat patients, we do that in a variety of the environment, and the treatment within these activities are focusing on the patient needs and demands. Motor learning is a crucial part of the philosophy of the PNF, as with the motor learning and using the basic principles which are characterize this, use it or lose it, use it and improve it, similarity and specificity, It's a crucial part of this conception. Basic principles. These are the basic tools for the stimulation of the central nervous system. The goals around the basic principles are to improve the motor control, the ability of the patient to move or to remain stable, to enhance the motor learning, guide the patients within appropriate grips and resistance, and finally to improve the perception in all these sensory integration and acquired. Basic principles are separated, divided into proprioceptive stimuli, into exteroceptive stimuli, and to basic procedures such as patterns, irradiation, body mechanics, reinforcement, and timing. The third part of theory, the techniques that enrich the sensory motoric stimulation, consists of three groups of techniques. The agonistic technique, in which one muscle group is evolving into that action. Antagonistic technique, which involves agonists and antagonists, which focus in both directions. And finally, we have the relaxation and the stretching techniques, which are really focusing on the relaxation issue. I would like to present you now some clinical examples and to give you some little explanations of how a therapist can really use this nice conception, the PNF, within the different indications and different patients. If we see here, the resistance is applied on the superior and anterior part of the shoulder girdle, which facilitates this nice elongation of the trunk, so you can consider what happened in the spine. If the resistance is the resistance, which is the main guidance, really direct the patient into the willing direction. And now you see some little technique of hold relax in order to relax the upper trapezius muscles. The indication here is for shoulder, for the scapula. He likes to relax the upper trapezius muscles. Hold, relax, and then you see how these muscles are relaxing. And then again within the whole range. And now you see a nice eccentric control, eccentric contraction to relax all these muscles here, to prepare the patient for later on better actions within the glenohumeral joint. This is an example of PNF on mats. You see the scooting now. The body is moving over the shoulders and not really the shoulders over the body. That's the kind of indirect approach. You see now the adduction, internal rotation of the left shoulder, and on the other hand, the abduction and the external rotation of the right shoulder. You can work this in a stiffness, for mobility problems, on the frozen arm, etc. Here is another example. Patient is in sitting. This is a bilateral reciprocal pattern. You see the resistance is given to his left arm within the pattern of extension, abduction, internal rotation, and then the other arm, which is raising up. Now use some specific terminology, flexion. You see on the right shoulder, abduction, external rotation. You can recognize from the anatomical movement, but that facilitates all this nice extension of the upper trunk in order to reach better range. And on the right, again, this is another example of working on mats. quadrat position. Therapist is giving resistance through the pelvis, so the patient has to sit on the right leg, and that indirectly can mobilize the right humeral joint, the right shoulder, and to increase the range of motion, while by changing the techniques, the therapist can use also relaxation techniques in order to improve the mobility of the right shoulder. Here is another example. This patient has a weakness on the left leg, especially on the iliopsoas, and this is a sign-lying position, which again, resistance are given in all directions, all three components of this pattern: flexion, adduction, external rotation. Now you see the therapist asks from the patient to really step on his right groin, and by pushing his left leg while he's practicing the pattern within the gravity, which makes it a bit easier for the patient to use his right iliopsoas as a hip flexor. The other example, you see it's a very dynamic process. Now you see an indirect treatment. This is a chopping to the right, and the resistance is given to the trunk through this flexion pattern, flexion, rotation to the right, which facilitates, as you can see, the reaction of the right hip. So this is through this irradiation. You can see that the flexors of the right hip are working in a position which is against the gravity. That's really nice facilitation for the hip flexors through the strong muscle, from the muscles of the trunk. Positive approach, irradiation, again, indirect approach. This is another example here, which you can see that the patient now tries to reach this cup, which is on the cupboard, and the therapist again uses his strong left arm in a strong direction. You see the left arm, and while he's practicing on the right arm within the pattern of flexion, adduction, external rotation, in order to increase the ability of the patient to raise his right arm as high as possible to reach the cup on the cupboard. Here is, on the right, is a different example. You see here, this is a lady who had an accident and she has incomplete paraplegia. This is a facilitation through this activity to help her to stand up while we're practicing within a technique of combination of isotonics. The eccentric control, and then right after the concentric control for standing up. Different examples just to give you an idea how we use this concept. And here are some examples of motor learning. This man is after a brain injury, so he has a very weak grip. He tries to bring it to his mouth. You see, he compensates a lot through this flexion spastic pattern, and now the therapist is guiding him very easy with his resistance and try to make it possible for the patient to get the experience of this successfulness. And here is another example. Therapists resist the right affected arm of this. This is another example of a patient after brain injury. He tries to drink from the cup while the therapist at the same time gives resistance to the trunk to now changing of the grips, finding the proper gripping in order to make it possible for the patient using his strong trunk flexors to facilitate these flexors of the arm in order to make possible to drinking from the cup through a motor learning process. I really like to thank you all for your attention. And if you are really interested to learn more about this concept, about the PNF, this wonderful concept, I really would appreciate if I see you soon in one of the PNF courses which we prepare for your capital city, Tirana. Thank you very much.